Okay, thank you very much, Diego. I do, again, financial disclosures with Horizon Pharma. Targeted agents, this is really the future of oncology and rheumatology treatments. The reason is that we can provide more precision with fewer side effects. And I think this is something that's not going away. So something that we ought to know about. With regards to orbital eyelid and lacrimal disease that's amenable to targeted therapy, I think we have oncologic conditions as well as inflammatory conditions. So treatment of, traditional treatment of orbital malignancy, we use surgery. However, this can be disfiguring. Sometimes it's incomplete, sometimes it causes problem. Radiotherapy can affect adjacent structures, especially the eye, like we said, retinopathy, even optic neuropathy. And then we do have traditional chemotherapy. However, this can affect normal populations of cells, cells with high mitotic rates. Same thing with orbital inflammatory disease. We do have medical therapy for these, but most of these are nonspecific agents, such as prednisone, methotrexate, cyclosporin, and there are side effects to these. So nonspecific. We also have surgical options for inflammatory disease, debulking, but again, with the potential to damage normal structures, and then also radiation, as we noted before, also this potential damage. So this is what the drive is for molecularly targeted agents. I think it's hard to first learn about these because there's all these relatively long words and you don't really know what it is. So we're just going to go over the nomenclature really quickly. Molecularly targeted agents can usually either be monoclonal antibodies or small molecule inhibitors. And you will know by the name which is which. If it ends with MAB, it's a monoclonal antibody. If it ends with IB, it's a small molecule inhibitor. Monoclonal antibodies you can look at their name and you can figure out what they target and also how they were made. The way in which monoclonal antibodies work is that they target specific antigens. This is almost always either intravenous or subcutaneous therapy. So this is an injection. It usually targets transmembrane receptors, extracellular growth factors, and you can even conjugate it with radioisotopes. The mechanism of action, basically, you can have an antibody to a soluble or circulating growth factor. You can have an antibody to a specific marker on the cell. Or the big thing now is you can have an antibody to the checkpoint, to a checkpoint in the immune system, as we had heard earlier. With regards to small molecule inhibitors, again, you can tell what these are by the name, depending upon how it ends. So if you know that it ends with TINIB, you know it's a tyrosine kinase inhibitor. So easy things to sort of pay attention to. When these agents first came out, I almost made myself look at the name and try to figure out what was going on. The issue with small molecules is that the advantages that it's usually oral therapy, so not a shot. They penetrate the cell membrane and usually interfere with some metabolic or enzymatic step in the cell. So let's talk a little bit about some of the classic oncology molecularly targeted agents: vismodegib, cetuximab, and rituximab. So we know that the first one is a small molecule inhibitor. It ends with IB. We know that the last two are monoclonal antibodies because they end with MAB, and we know that they're made against tumor antigens because they have the TU in them. So vismodegib, this is an inhibitor of the hedgehog signaling pathway, and this is used in the treatment of metastatic and locally advanced basal cell carcinoma. So these are the patients that we would usually send for exoneration in the past that now we can try to shrink down the tumor with a medication. It's also very useful in treating those patients with basal cell Nevis syndrome. The downside to vismodegib, though, is that it does have significant side effects. So 30% of patients that are started on this medication will stop it due to the side effects. So this is one of the initial papers showing a patient before and after treatment with vismodegib who has basal cell Nevis syndrome. So multiple basal cells, genetic predisposition to developing basal cells, and you can see the response. So pretty amazing. Now, another medication is cetuximab, which is an anti-epidermal growth factor receptor antibody. And so epidermal growth factors are expressed on squamous cells, and so this is very good for any of those squamous cell carcinomas, colorectal cancer, head and neck cancers. and it's overexpressed in cutaneous squamous cell carcinoma. However, it's also present in a lot of other things, and we'll see side effects secondary to that. So here's a patient before and after treatment with cetuximab for a advanced squamous cell carcinoma. There's also some small molecule inhibitors that affect the epidermal growth factor receptors that also have shown success in treating periocular squamous cell carcinomas with orbital invasion. And so this is sort of the difference. You know, we see cetuximab at the top, it's extracellular, it's floating around in the blood, whereas with the small molecule inhibitor, it's actually inside the cell. So it's a small molecule, and you get inside the cell. Monoclonal antibodies do not get inside the cell. So again, a patient before and after treatment with one of the small molecule inhibitors for a patient with orbital invasion of a squamous cell carcinoma. Rituximab, we heard about it earlier in treating inflammation, anti-CD20 antibody used as monotherapy or in combination chemotherapy for lymphoma. So we'll see this a lot in our orbital lymphoma patients. So when we look at these last three drugs, they were really developed to inhibit specific pathways in specific cells. This is a relatively labor-intensive development. So what has happened lately is that there's a number of intracellular and extracellular pathways that drugs are known to inhibit, and we started taking those off the shelf and tried them out on different diseases. So we have all these other pathways in the cell. There's a number of known drugs that inhibit them, and the idea is to just sort of start taking these drugs and with a educated guess, use them in some of these diseases where we know some of these pathways are being used. So for example, for the BRAF inhibitors, there's been success in the treatment of orbital involvement of Erdheim-Chester disease. Erdheim and Chester disease is associated with a mutation in the BRAF gene. With regards to vascular tumors, there's been success with some of the anti-VEGF monoclonal antibodies, as well as even injection in an apical cavernous malformation that has shown shrinkage. So people are starting to take some of these drugs, not necessarily developing specifically for processes, but taking known drugs and saying, well, we know some of these pathways are involved with some of these other tumors, so let's try it out and see what happens. So sort of exciting with regards to what people are doing now. Rather than trying to just find a specific molecule, they're taking known molecules and trying them out on different diseases. In NF1, the MEK inhibitor, selumetinib, is found to decrease the volume of plexiform neurofibromas in kids with NF1. And then there's also been some success described with sirolimus for patients with lymphatic malformations. So again, before and after pictures from the New England Journal article in kids treated with selumetinib that had big plexiform neurofibromas. So I've had about 3 kids at this point that I've sent for treatment, one of which has responded, the other 2 have not responded, but it's sort of these kids that you look at and you know that, big surgical options for them, and so I'm starting to try them on these MEK inhibitors to see how we do. With regards to treatment of orbital inflammation, we went over this briefly when I was talking about thyroid eye disease. Again, this targets cell receptors on lymphocytes, targeting cytokines in the plasma. Most of these are monoclonal antibodies. Again, we talked about rituximab earlier, applications, IgG4 disease, GPA, mucous membrane pemphigoid, et cetera, et cetera. So again, adult onset xanthogranuloma, something that you could try in that case that we saw in the cases section earlier. TNF-alphas have been used in idiopathic orbital inflammation as well as orbital myositis. Tocilizumab, as we had noted earlier, again, success described with thyroid eye disease, IL-6 receptor antagonists, and then, as we had noted earlier, teprotumumab, insulin growth factor receptor antagonists. So one of the big things lately, though, is this thing called immunotherapy, and basically what we're doing within immunotherapy is taking advantage of the host's immune system to fight abnormal cells. So we know when we see this in our practice that a healthy immune system is needed to prevent the development of neoplasms. We know that immunosuppressed patients develop a lot worse cutaneous, non-melanoma skin cancers. We'll see that in our patients that have had organ transplants, as well as those patients with CLL. And basically, two pathways are currently targeted, the CTLA4, and then, as was noted earlier, the PD-1 pathway. The best way to think about these molecules is that basically you are just unleashing the immune system. We have these checkpoints in our immune system that try to dampen an immune response, and what these monoclonal antibodies are doing is blocking that so that the immune system can be revved up. And we see that with both the CTLA4 as well as PD-1 inhibitors. And so in doing that, we can mount an immune response more than what would have been there to these tumors. And so there's been advantages and benefits shown in treatment of squamous cell carcinoma with some of the PD-1 expression, sebaceous cell carcinoma, and then there's been a few case reports out there with lacrimal gland carcinoma. So I think there's definitely things out there that we're going to be treating that we wouldn't have treated before. So here's a patient with a squamous cell carcinoma being treated with one of the PD-1 inhibitors. But I think also what we need to realize is that a lot of these treatments do have side effects. And so even though they're targeted to molecules that are on the tumor cells, there's also a lot of these molecules that are present in normally present in cells. Some of the oculoplastic side effects that we see, so for BRAF inhibitors, we see keratoacanthomas as well as squamous cell carcinomas. With the EGFR inhibitors, we'll see disorganized hair follicles, and I'll show you a slide of that. And then with bortezomib, which is a proteasome inhibitor, you see a lot of chalasia. And so I'll see that actually in my practice when I'm over at MD Anderson. So here's a patient on an EGFR inhibitor. Lashes are incredibly long. He would come to the clinic to get his lashes cut because they would grow so long. They'd grow an inch or two, 3 to 4 centimeters in length. Tyrosine kinase inhibitors, we also see periorbital edema. Now, with regards to immunotherapy, we're also seeing a lot of interesting side effects. So since we're revving up the immune system, we're going to have some of those side effects from an overactive or misbehaving immune system. So orbital inflammatory disease, uveitis, scleritis, there's even been induction of thyroid orbitopathy, and also lacrimal gland inflammation. So lots of side effects from these cancer immunotherapies for checkpoint inhibitors. Also see poliosis, and then recently there was a report of inophthalmos in a patient being treated with one of the immunotherapies. So take home to me is, take advantage of these newer therapies in the care of your patients. They're not going away. Involve your medical oncologist as well as your rheumatologist in some of these tricky patients. And then also ask your patients about their cancer history, because a lot of times we'll have patients that have a history of cancer that are on some of these medications and will come in and have some of these side effects. So things to know. All right, thank you very much.
Thank you, Richard, for the very extensive lecture.